Good evening, everyone. Welcome to our webinar. My name is Dr. Abdulkani Kasim, Executive Director of Nursing Department of Continuous Education and Professional Development in the General Department in Health Services. And I will be serving you as your moderator today. You will be hearing a presentation from Mrs. Mawahib Wang. Tonight, she will be speaking on the value of safe staffing. Ms. Mawahib Wang is the Executive Director of Nursing Administration at the Ministry of Defense Health Services, overseeing nursing department in 25 military hospitals. Ms. Mawahib has an extensive experience both in clinical and managerial areas. Her areas of expertise include critical care nursing and leadership. Ms. Mawahib graduated from Walden University in Minneapolis, Minnesota, with a master's degree in healthcare management and leadership. SBSCC reminds you that the abstract submission for the third SBSC patient safety is open. Kindly scan the barcode or visit the SBSC webpage to submit. Now is a great pleasure that we move along to our session and to welcome Mrs. Mawahib Wong to deliver the presentation on this very timely subject. Kindly note that the questions will be at the end of the session and be posted in the Q&A icon, so our speaker will be able to answer them gladly. Ms. Wahib, welcome.
Thank you, Dr. Abdi, for the introduction, and thank you for the Patient Safety Center for hosting this webinar. I think this webinar, this topic, it's really needed to be talked about across healthcare and outside healthcare also. And I would like to start by the definition. Can we go to the first slide, please? So we always talk about value-based healthcare, value, care delivery. Let's first of all go to the definition of what is value in healthcare. Can I go to the next slide? So by definition, value in healthcare is measures the improvement in patient health outcome for the cost of achieving the improvement. So the goal of the value-based healthcare really is to enable the healthcare system to effectively and efficiently work, giving the patient the best outcome. Next. But it's not only about the patient. It is really basically it's about the healthcare workers. When healthcare workers feel that they have a purpose, when they feel that the care that they're given is adding value to the health and the well-being of the population that they're serving, they feel sense of satisfaction. You feel like those people that go to work and say, oh boy, I love going to my work. I love my patients. I love my colleagues. It's because they feel like they're adding value, and it prevents, even though we have a lot of pressures in healthcare, this feeling of satisfaction and purpose prevents burnout and people leaving healthcare profession. Next. So let's basically, first of all, talk about what is value-based healthcare meaning to all the stakeholders. So to the patient, it means the care that I got gave me the best outcome possible with the least cost. It doesn't mean that we save money, we get worse healthcare. No, we get the appropriate healthcare. For the provider, especially for private sector, it means higher patient satisfaction, and it's a driver for the business. For the payer, the insurance, or whether it's the government, it is decrease in the cost. For the supplier, even if you remember at the time of COVID, we had a huge issue in the supply management globally, and specifically right here in our country. There were times where the N95 were not available because it was unexpected surge in the need, and it was very costly. So some companies, they charge the hospitals way over the price just because of the supply and the demand. Then for the whole society, for all of us as a whole, the more we deliver healthcare that is appropriate, that is not overpriced, the less taxes we pay, the less cost for the entire government to spend on the healthcare. So it's a win-win-win-win-win situation if we learn how to deliver the appropriate healthcare in appropriate time for the best outcome. Next. So let's have a little bit of an overview of how the healthcare systems are operating around the world. In developed countries like UK, Canada, Netherlands, it is estimated that around 5% of all the deaths that happen inside healthcare facilities because of issues with safety. That is a huge number if you look at it. But when it comes to the lower middle income countries, it is way more. 1 in every 4 patients in a hospital setting actually gets harmed. 1 in 4. And actually 1 out of every 24 people who go in a hospital in the lower and middle income countries die. Even when in 1999, when that big report came from IHI, 1 in every 10 patients across the globe get harmed during healthcare delivery. It hasn't gotten better. We still continue with the same rate. Next slide, please. So when we talk about harm, we don't only look at the loss at the hospital level. We look at the cost of human lives. Every person who dies affects many other people. They have families, they have children, and if they die, there is a loss of income for that family. The other parent might become a single parent, and then life becomes harder, and then the society as a whole suffers. Yet, we're still having the same rate of 1 in every 10 people getting harmed in all hospitals across all settings. But the scariest of all statistics is the one that WHO estimated. That's 134 million adverse effects happens per year, causing 2.6 million deaths that are preventable in lower and middle income countries. Think about that. 2.6 million people die, affecting 2.6 million families. How is that affecting not only the family, they're affecting the economy of that country. Next slide. So we know that healthcare delivery costs money. If I ask you today, do you know how much do we spend? Only Ministry of Health in 2021 and 2022 was allocated 79 billion reals, which is 7.82 of our GDP. This is a growth of 59% over the last 10 years. The healthcare demand is growing as the population grows. And as the population grows in number, we're also aging because the life expectancy is growing with the better healthcare that people are getting. So there is no expectation. Every single country is going to be spending more and more money. Around the globe is around 9.5 on the average on the GDP of a country that people spend, governments spend. So as healthcare providers, and I'm pretty sure that almost everyone on this webinar is a healthcare provider, has to keep in mind the how they can give the best care possible with efficiently. Next slide. So we always talk about cost and value, and steering room committees that we have in the clusters in the private sectors, we're always talking about how do we utilize our budget best. And one of the biggest expenditure of healthcare is the wages of the employees, whether they are healthcare clinicians or their support service or their administrators. The biggest part, the chunk of the budget goes to healthcare workers. And everyone who works in a healthcare facility, we're going to name it as a healthcare worker, whether they're clinicians or non-clinicians, because they work in a healthcare setting. So these meetings and these allocations really can get heated up. Next slide. Next. Can we go to next slide, please? Yeah. So having said that, let's look at the largest workforce that we have in healthcare setting. Normally, any organization that is working efficiently has about 40 to 60% of their workforce is nursing staff in the nursing department, whether they are RNs or they're, support service, or they are, administration that works in the nursing department. So it is only natural to look at this budget and say, how can we save money in nursing? How can we cut the nursing numbers? But that's really is the wrong question, and we'll answer it later. So nurses do not bring patients in. In private sectors, we go to the hospital where we like the physician. We know physician so-and-so has a good reputation. The surgeries are always without complications. I'm going to go to him, or I'm going to go deliver my baby with this OB/GYN because, they have a good outcome. So they bring in. Whereas nurses, we don't bring in patients. We take care of patients, and therefore we're considered expense. Also, we have low representation in the decision-making across the healthcare sectors, whether it is within a healthcare facility or healthcare sector. If you look at the different healthcare sectors that we have here in Saudi Arabia, we have the clusters now, we have Ministry of Defense, we have Ministry of Interior, we have National Guard, we have the private sector and Ministry of Interior, right? So if you look at the boards and the administration where decisions are made in these boards, I want you to really pay attention how many nurses are sitting there when you compare to the other healthcare workers, such as physicians. There's also a big lack of understanding of the value that nursing brings to healthcare. So if we as nurses do not educate ourselves first, and then educate our colleagues and educate the whole society, then we're not going to be able to get our share of the budget that we need to operate safely. Next slide. Next, please. So even though research and literature shows that when you cut nursing, you get worse patient outcome, it's still the practice is ongoing. And it's not only ongoing here, it's ongoing globally. The nurses are the first ones to be cut. When you have a ratio of 4:1 in the surgical wards, they'll give them 6:1, increasing it by 50%. But really, they're saving pennies on the dollars, and the health outcome is a lot more costly, as we will see soon. Next slide. Next. So our goal, our target should be, how do we justify the return of investment in nursing? This is the language that we all need to be speaking. How do we make our decision makers, whether they are in the sectors higher up or whether at facility level, understand what is the value of nurses? And let's not forget about midwives in our facilities. Next slide. So in order to do that, we need to know some facts, okay? And facts are, you can find very strong documented evidence on when we have proper staffing for nurses who are competent and well-trained, we have decrease in all types of complications, both surgical complications, GI bleeding, sepsis, shock, pulmonary failure, pressure injuries, falls, and much, much more is decreased when we have proper staffing. Next. We also know, specifically in the ICU area, and I hope that we have many people who work in the ICU right here in this webinar, we know how difficult it is when you take more than 2 patients in ICU. Sometimes we need one-on-one, and sometimes we even need 2 or 3 nurses to 1 patient when they are very critical and they need higher care, level of care. If we look at something as simple and fast forward as CLABSI rates, when you have the proper staffing, you will have 60% lower CLABSIs. And this makes sense because if I have 3 patients, I'm going to be taking care of keeping these people's life alive. I'm not going to be taking care of dressing. I'm not going to pay attention as much because I'm trying to do shortcuts because I'm trying to keep my patients alive. So keeping proper ratios in ICU is very important, and it improves patient outcome. CLABSI, it has very high risk for patients to die. Mortality rate is high, and even the expense of treating when it happens is high. Let's go to next. And it's not only about patient outcome. What about nursing satisfaction? Let's look at who are the happiest nurses around the globe. The happiest nurses around the globe are those nurses where they have strong unions, where they have mandated ratios and safety checks in the system that will help them deliver the patient's care safely and prevent them from being burned out. So if we see like the Californian results, when in 2004 and 2008, they had decreased nursing turnover for 4 consecutive years because the nurses did not feel that they were burned out and they were not leaving the profession. What happened after COVID is many nurses were driven to leave the healthcare profession as a whole. The UK estimated that 38% of the current workforce that they have will leave nursing. Imagine that, almost 40% of your nurses, you're already short-staffed, and 40% of your nurses decided to leave healthcare because they feel like they cannot cope anymore. So giving them appropriate number of patients to take care of is very important in keeping the nurses satisfied. Next slide. So there was also another positive outcome for the ratios. Those nurses that already were burned out and left the profession, 20,000 nurses came back in Australia when they mandated the nursing ratio, because nurses felt like, okay, I can go back and I can give proper care without, risking my own health, risking my own license, and make a decent living. So that's also a way back to bring back nursing. Does anyone here know what is the rate of dropout nurses in the country? It is very high. One of the studies that was published, I think it was 2015 or earlier, showed that 50% of the graduate nurses get out of nursing within the first 5 years. That is a high turnover for nurses. The economy has changed and things have changed and more people are going into nursing, but we still do not have enough nurses to cover the nurses we need. The ratio of nurses to physician in the developed country is about 1 to 4, 1 physician, 4 nurses. The ratio that we have in Saudi Arabia is 1 to 2. I want you to think about that. Go back to your hospital and find out how many physicians you have versus how many nurses you have, and then do the ratio. It might be an eye-opening experience. Let's go next, please. Next. Okay, so what happens when we have poor staffing? That nurse, just like is a typical nurse that I see around hospitals. Nurses get really tired and frustrated, and they think about, when am I going to be leaving this job? The mortality rate will increase when the nurses are disengaged because they are way too tired and exhausted, and they don't feel like the administration care. Mortality rate will increase. The patient pneumonia rate will increase. Patients will not be mobilating as much, right? Unplanned extubation, because there's nobody to watch the patients, it will increase. We nurses will not pay attention to the signs of deteriorating patients. And that's why we have failure to rescue. Do you know what is the timing for the highest number of code blues? It is normally right before shift change. And the reason why it's right before shift change, especially the morning, it's because nurses all night long, sometimes because they're too busy, they don't check and see the patient deteriorating. And when they finally do their morning vital signs, they discover patients who already either died or is about to die. Nosocomial blood streams, collapses, they increase. And the length of stay also increase when you have poor staffing. Because if you have proper staffing, the nurses will be there educating the patient pre-surgery, pre-admission in the clinics. Then the day of the surgery, they're going to help them get up, mobilate them, and help them get out of the hospitals. If you have nurses that are too busy just giving out medications and documentation, then we will be late on promoting the length of stay. And length of stay is one thing that hospital administrations always look at, because the amount of money spent on each patient should be set per diagnosis. Next, please. So let's look at, again, let's try to be a little bit, I'm going in and out because I want you to have a very clear idea about what's happening here in the country and what's happening globally. So globally, WHO says that 83% of all maternal deaths, stillbirth, can be prevented with full package of midwifery care. Imagine that. So if a patient, a pregnant patient, follows up regularly with midwives, whether they are in a hospital setting or outside hospital setting, 83% decrease in mortality and morbidity. And actually 87% of all newborns can be delivered by midwives. Think about it. A long time ago, we didn't have physicians, we didn't have C-section. What is the rate of C-section in your hospital? Is it below 30? Is it 45? I've seen it as high as 45%, which is very high. With midwives, they decrease that rate for a safer delivery for both the mother and the baby. Next slide. We should invest more in our midwives. We also have reduction in preterms when a midwife cares for the regularly see the baby. And I don't know if any one of you had a preterm baby, but my cousin had 3 preemies and they stayed in the ICU for months. Thank God they're Saudis and they didn't have to pay out of the pocket. But a country like United States where a person pays out of their pocket if they don't have, it can go up to 225 billion per baby. So with her 3 babies, that would have been like $7,500,000. Next. So look at this. The return of investment that we talked about earlier. This is the report that came out from the WHO midwifery. It says investing in midwifery education with development of community-based services actually comes back with a return of investment of 16 folds, 16 times, okay? And save lives at the same time. This is a very good case that we can make that we need to have midwives in the primary care settings so they can follow up the patient from the beginning and can recognize signs that this pregnancy is not going normal and can refer them earlier instead of emergency deliveries. Next. So how much does it really cost to educate our nurses and the midwife? How much do we spend? We said nurses and midwives are more than 50% of all healthcare workers, right? Yet their education, we only invest in 25% of the education goes to nurses and midwife. This is not balanced. These are the numbers of people that you need, but you're spending so little on their education. This report came from the OECD in 2020, and it's urging governments. This report went to governments to allocate more budgets for training of nurses and midwives. And these people are not even healthcare. They're financial people, but they do understand the effect that we have on the government spending the money on healthcare. Next. I don't know if anyone disagrees with this, but I am biased. I know I'm a nurse, and I do feel that nurses are the heart of all healthcare in all the settings, whether it is primary, it is tertiary, it is secondary. If you do have good nurses that are engaged with the proper numbers, with the right education, I guarantee you patients will be happier, healthcare workers will be happier, and outcome will be better, and we would be spending less. Next, please. So all of that is evidence and talk outside the country, right? Every single one of us can make a business case for proper staffing. If you only look at your KPIs, the nurse-sensitive KPIs, concentrate on the nurse-sensitive KPIs because they're called nurse-sensitive for a good reason, because the nursing-driven and nursing have the highest control over those KPIs. So let's look at this case that we did in one of the hospital. Next slide. So in one of the hospitals, we had short staffing in 2016, and it was a little better 2017, and in 2018, we resolved the shortage in that hospital. You could see the nursing satisfaction, how it was. The yellow, the black line tells you the average, okay, or the 50th percentile, and the yellow is the mean, okay? So we were below the average and the mean when we were short staff. And do you know how much short we were then? Only 20%. And the nurses were this dissatisfied. Imagine in some of the hospitals right now, we have 40%, 50% vacancy rate. How are the nurses coping? They're definitely very dissatisfied. Next slide. So then the nurses were asked in those, are you satisfied with the care you give? Remember in like the second slide or so, I said value-based healthcare is not only about outcome of the patient, and it's not only about saving, but it's also provide meaning to us as healthcare workers, that we really did spend enough time with our patient, taking care of their needs, making them well, feel better and making them well, and therefore we are satisfied. So the nurses previously felt like they were not satisfied with the care that they gave. If you ask the nurses then, she would say, well, if I had more time, I would have done a better job. So next slide. This is the number of missed care. So the question asked, have you done all the skincare that you needed to do? So the number of missed care was lowest when the nursing staffing was the highest. So the higher the staffing ratio, the better skincare the nurses gave, the less pressure injuries, the less infections that we had. Next. And this is really one that I'm very passionate about, which is central line infection. So when the nurses had enough staffing, they actually were doing a good job in the central line, taking care of their patient's central line. Next. As you could see, this resulted in 48% decrease across the time when we were less staffed to the time when we were properly staffed. And we calculated the cost of savings estimated on the cost of CLAPSI per case to be 2.4 million in that year. Next. Same thing with the CAUTI. The CAUTI cases also decreased. We maintained 0 CAUTI, and the cost saving was estimated as 623,000 reals. Next. So if we put together the cost of all the savings that we did when we had proper staffing, and it was about 4 million reals during that year. 4 million real can get you a lot of nurses. So we made the case for our administration that we must maintain proper staffing in order to not to use our budget on treating complications that result from short nursing. And with this, we didn't even include the number of hours of overtime that was spent and paid. We didn't include the turnover rate and the recruitment. Having the proper nurses stay and satisfied in the same hospital yield a lot of savings from many, many different angles. I would be really glad to be in touch with anyone who wants to go deeper into their facility and look at that, because we look at way more than just these numbers when we look at how do we value nursing in healthcare. Next. So let's talk about, since we talked about this webinar is about the safe staffing and the value of nursing. Let's talk about the start. It all started in sometime before December 2018, and where there was an incident of that triggered this. And then in 2018, December of 2018, the Patient Safety Center and the ICN did a congress, and this was presented. Then in March of 2019, in Jeddah, we had the Global Ministerial Summit, where 51 countries joined this. And we also presented the case for safe staffing, and it was very successful and brought in a lot of healthcare experts and state members to pay attention to this. Then in 2019, the white paper that came out with a collaboration with Saudi Patient Safety Center, the Nursing Association, and ICN came out. And the Nursing Association in 2019 adopted that in all the hospitals, recommended that. It was not a mandate yet. And then the Safe Staffing Initiative started, the implementation part started in April 2020. So it took a work of almost a year and a half to get the preparation on studying and looking at how we can, as a country across the board, implement safe staffing. Next slide. Then in 2020, the Saudi Council, which is the highest governing body in healthcare, approved the safe staffing proposal, and the official safe staffing manual came out August 2021. In December 2022, the Sibahi was very supportive and accepted to make it part of the new edition that is coming out in 2022. And you will see in the new edition a chapter called Safe Staffing. Now, I'm glad to say that nursing inspired other disciplines to look at their own staffing. So you will see physician staffing in different areas and other clinicians staffing. So that is part of the upcoming Sabahi edition. Next. That was the Memorial Day of the Global Patient Safety Summit. If you can see, right next to me is Dr. Tedros from WHO, and next to him is Howard, the president of the ICN. And you might see some familiar faces there. Some of our nurse leaders who are there, Dr. Ahmed, Hausawi, Dr. Abdul Ghani, who's a moderator, is there. Next to him, that guy with the white hair, that's actually Berwick, Don Berwick, if you know him. It's one of the founders of the IHI. And then on the other side, you could see Miss Sophia, Dr. Ilham, Miss Teresa, some of the leaders that I don't know their names sitting there. Next. This was also a Memorial Day when the Saudi Commission signed an agreement with the Patient Safety Center and the Nursing Association to launch the patient safety ratio. Next. In 2020, this is when the implementation happened. The nurse leaders from all the sectors get together to see how we're going to be implementing this in a practical way in all healthcare settings, whether it's governmental or private. So we have representative from all the sectors, and we had representative from even private sectors to help us put the recommendation that was adopted later on. Next. This is just to show that the 4th edition that is coming is going to have that ratio. Inshallah, it's not out yet officially, but it will be out soon before the end of the year. Next. I wanted to really end by this quote by the American Nursing Association. Only by determining the economic value of nursing to patient, healthcare organization, or corporations will the profession be able to capitalize on its contribution to healthcare quality and overall healthcare and well-being of the society. In order for us to get more support for the nursing profession, in order for us to increase the number of seats in the universities and the college, in order for us to have higher pay for nurses, so more people will be attracted to the profession, we first ourselves must educate ourselves on the value that we bring. So if you take your hospital and you sit down with your quality department, look at your nurse indicators, look at trends, always correlate your nursing KPIs with your staffing. And I'm pretty sure it's going to show a clear story that will support your case to get the staffing that you need. Thank you. I think that was the last slide, Abdi. Next, we're done now. We're done. I'll be more than happy to take any questions right now.
Sorry, I was muted. Thank you so much, Ms. Mawahib. We really appreciated taking the time for addressing this important topic. And now I would like to invite the participant to post any question they have, and we'll be gladly to answer. Kindly use the QA icon, so Ms. Mawahib will be able to answer your question. In addition, also, I would like to announce the registration for the 5th National Patient Safety Award is open with the show tracks. Deadline for registration will be on September 30th. Question and answers, please. You are all welcome. There is a question that says, and been asked by Mr. Ahmed. Thank you very much. Mr. Mawahib, how about the operational cost?
Well, the operational cost is the reason why nursing is considered as an expense, but is a necessary expense in order to get the outcome that is needed. So operational cost is not only the nursing hours that is worked, but it is everything else that is associated with keeping patients inpatients, whether they are, the cost of maintaining the room, the catering, the medication, is all of that is considered part of the operational cost. And there is another question by also the same gentleman, Mr. Ahmed. He asked, what do you think about home healthcare projects, since nursing service are the most revenue of these projects? It is true. Nursing home health projects actually saves both the patient, the hospital expense, and the payer. So we do not have, in Saudi Arabia, we do not have enough home health. There are more patients that need home health and can be maintained outside the hospital, which is actually safer for the patients, prevent them from having infection, but at the same time, cost the institution less. So we encourage nurses to go ahead and go open your own business and be in home health.
Thank you very much, Ms. Mawahib. I'm not sure if there's any question from the audience. Okay, Zahra is asking, is there any change for nursing staff ratio or same as Saudi Patient Safety Center?
We are all adopting the final proposal that came up from the Saudi Patient Safety Center. The Ministry of Health is adopting it, and other government sectors are adopting it too.
All right, thank you, Ms. Mawahib. Let's see if there's any more questions. All right, let me ask you this question. If I have a couple of questions until we have question from the participant. Could you share with us how did this journey of safe staffing all started?
Yeah, it actually started in 2018, about, I would say about maybe April or May in 2018, when the first cluster was formed in the Eastern Province. And an eye-opening incident really happened that day. One young nurse was taking care of 30 patients in a pediatric medical surgical unit. And to me, that was unacceptable by all measures. It was setting up for medical errors to happen, and setting up the nurse to be burned out. And that was the trigger of the safe staffing movement in Saudi Arabia.
All right. Let's see if we have more questions. Okay. When you say safe staffing, does it consider the nurse and the patient ratio?
Yes, of course. That's what it is. It's based on the acuity of the patients in a setting. This is very broad. Okay, it's the minimum number of maximum number of patients that you can have. So when we say the maximum number of any nurse can have in the critical care area is 2 to 1, then it means that hospitals should not give nurses 3 to 1 or 4 to 1. I heard about some private sectors sometimes going as high as 7 to 1. So this is when we're setting up the nurse to make medication errors, sometimes fatal medication errors, just because she doesn't have the time and her colleagues don't have the time to help her check whether it's medication or blood transfusion that require 2 people checking. So it is the same.
All right, Alex, we have a question. Good evening. As we all know, the nursing profession keeps on evolving. Do you think using humanoid robots in nursing profession and practice be useful as we consider safe staffing? Interesting.
Yeah, really. This is the kind of questions that some of the non-healthcare people suggest. How can technology? There is an interview that's going to come out in soon that asked me that very same question. How can technology help with there's no replacement, first of all, for the human factor, for the human care, especially the nursing care. But you can definitely help. Automation always is helpful. If you have a hospital where the nurses have electronic medical record, for example, where the vital signs are taken from the monitor and automatically goes to the EMR, the nurses don't have to spend time on that. That is saving the nursing to do more tasks that is required, like assessment or patient teaching or nutrition or something else that a machine cannot do. But there is no replacement for nursing.
Thank you, Ms. Mawahib. We have Naif. Thank you for your efforts. My question is about how can we encourage nursing sector in short term? I guess he's talking about the nursing profession or nursing leaders in the short term in order to achieve safe patient care.
Well, first of all, Naif, thank you for this is a really good question. We need to talk outside nursing. What happens is nurses talk to nursing, such as in this webinar, and we talk about the importance of staffing, but we don't go outside and talk to non-nursing. And every one of us, if we talk to everyone we meet, I almost talk to people that I see on the street and educate them about the importance of nursing. It needs to reach everyone in the society because guess what? Everyone is touched by healthcare. Every single one of us will either have a baby, will have a mother who's dying, will have a brother who had a heart attack, everyone is touched by healthcare. So if we talk to everyone, you will see that everyone collectively will be more aware. So when it comes to decision-making and budget allocation and setting value on nursing salaries, then if people are more educated, then they will be an advocate for us. So Naif, I encourage you to talk to your family and everyone that you know about the importance of nursing and how having proper nurses who are well educated is going to not only save lives, but it's going to save cost.
Thank you. I have an anonymous attendee. Any medical negligence happened, especially in critical care area due to nursing shortage and excessive workloads, but the blame will be put on the nurse, him or herself, instead of looking for the solution by the management. What's your opinion to improve this environment? I think it's a blaming environment.
It is. And nurses are always like I hate to use this term, but it's true, is the weakest link, is the people that don't have the voice. So a nursing administration should stand up for the nurses and make sure that, first of all, we prevent the mistakes from happening by having proper staffing. I'm going to tell you, when I was a much younger nurse, when I was a head nurse in one of the ICUs in Houston, Texas, we had severe shortage at that time. It was it was in 2000. We had severe shortage and we had a nursing CNO who did not understand what does that meant in reality. So when I called and asked for more agency nurses, she said, no, the budget is not allowing. We already spent all the money. Just assign the nurses to take the patients. So I said, please come to the ICU. So she came to the ICU. We both stood in front of the board. At that day, we had 16 patients, all critical. and we had 4 nurses that were coming in. I said, what am I supposed to do? Give 4 patients to each nurse? She said, yes. I told her I cannot. She said, this is an order. I told her, you do it. And I gave her the crayon literally in her hand, and she did it. At that day, I quit that job because I felt like I did not have the support that I needed to care for the nurses that were working with me. So you have to stand the stand. If you're getting patients way more than your assignment, you need to talk to your charge nurse, your head nurse, and say it out loud. Say, I am not comfortable with this assignment. Things happen later on. You already had said, and it's documented that you said, I'm not comfortable. I hope that answers your question.
Okay, this is more technical. How to prepare and calculate the hours in Mumaris Plus? Or maybe that has nothing to do with us. So that's semi hours.
Nothing to do with
Okay,
it, yeah.
sorry. It says any change for nurse staffing ratio, or I think you answered that question too.
I think there's a question, Abdi, here about what is acceptable vacancy rate.
Yeah, that's what I was looking for. Yeah.
That's a
Go
really
ahead.
good question. Vacancy rate is important, but also the hospital occupancy rate is also important when you're doing calculation. So if I have a vacancy rate of 30%, but my occupancy rate is only 60, do I really need all these nurses? Maybe I need to redo my staffing. But generally, vacancy rate less than 10% is acceptable. We know that nursing is a revolving door, and there's always, because of the large number of nurses, there are always going to be nurses going in and out. But anytime that you see the vacancy rate creeping up to 20 and above, know that you're heading for trouble. I hope that answers. And then somebody wants to know where they can access the patient, where they can ask registration to. No. That would be on the website, I would imagine, of the Patient Safety Center, since they put it out.
Thank you very much. We are going to conclude our 1-hour webinar on behalf of the Saudi Patient Safety Center. We would like to thank Mrs. Mawahib Wang and the audience for their active participation as a part of the Saudi Patient Safety Center's effort to provide you with a timely topic and interesting speakers. We would appreciate if you will fill out the evaluation survey sent to your email after the session. Thank you for joining us today, and we look forward to welcome you back in the future webinar. I thank you all. I thank you again, the audience, and also Ms. Mawahib for her excellent presentation.
Thank you, Abdi, and thank you everyone for joining us.
Thank you very much all.